Okay,
Yep.
was he on insulin?
He's on insulin, like
Oh, wow.
religiously on insulin, right? And he's
Not doing any
diabetic
good.
type 2. And when they stop the insulin, his sugar is normal. All it takes is that he doesn't need to eat sugar. So when he's
Good.
not eating sugar, low carb, his sugar is normal. So
Yeah,
what the
yeah.
hell? Why they put him on insulin?
Because that's all they know how to do.
Exactly. Right? So this is the problem. And then what he does, he cheats. He eats sugar and then he says, "Oh, I'm taking insulin, so that's fine." And without knowing that when you eat sugar and you take insulin, it's like putting a gas in the fire. Because insulin will ignite the free radicals, and then the sugar will be oxidized, and this will lead to glycans, and the glycans will lead to all the damage in the endothelial of the blood vessels, angiopathy, and angiopathy of the neurons, and this leads to degeneration of the tissue and ischemia and gangrene. And as you see there, that he has gangrene, so they amputate his almost 1/3 of his foot. And so the monotherapy of insulin is long. It's wrong. I mean, insulin is good for short term and for acute condition. We like it. It saves life. But when it comes into long term, you need to consider that insulin is a free radical generator. And if you want to give it, you need to make sure you're giving all other things that helps to navigate those free radical generators. And we're going to talk about them. And so insulin is considered a double-edged sword, same like nitric oxide. Nitric oxide also, in an environment where we have free radicals, it can turn into peroxynitrite and causing damage. So nitric oxide, you need to give them as well antioxidants, especially thiols. That's the reason when they give nitroglycerin patch, um, they find out if they mix it with alpha lipoic acid. And I think Dr. Quinn, he was doing that when we're treating. Do you remember the angiopathy? When we were treating neuropathy, we mix nitroglycerin with alpha lipoic acid.
Mm.
And the same thing for the heart. If you give nitroglycerin only, nitroglycerin will generate nitroxide. Nitroxide, if there's ischemia in the heart and you have those free radicals react with nitroxide, become peroxynitrate, and that leads to oxidation damage to the heart. And then when you damage the blood vessels, it leads to more ischemia. Then you need more nitroglycerin. That's why those patients with nitroglycerin, they need more and more of nitroglycerins because their blood, the nitroxide, it does vasodilation, which is good, but at the same time, if they react with free radicals, they become peroxynitrate, and it does the opposite, which is vasoconstriction and damage. And so, in order to prevent that, we mix nitroglycerin with alpha lipoic acid to neutralize those free radicals, so the nitroxide will stay in a good edge, the one that vasodilate and does not turn into peroxynitrate, which causes oxidation and damage. So insulin is also double sword edge. Estrogen as well, as we learned, that it's also double sword edge. If you have too much of it, it will turn into estrogens, and estrogens will lead to stimulation of activate the or conversion of the cortisone or cortisol into cortisone, and then you have an active cortisone, which is you end up from estrogen dominancy into a cortisone dominancy, and then cortisone dominancy leads to metabolic syndrome. Um, and so estrogen in a normal level is good for both male and female. But when it's high, it can lead to inflammation and damage, and it can lead to estrogen dominant syndrome, which we have a complete book on it. So my name is Dr. Halasa. I'm the founder of Chronic Disease Prevention and Management, and today we're going to talk about, insulin as a double sword or double-edged sword, and a system's biology blueprint to reverse diabetic mellitus and its complication through redox, metabolic, immune, and regenerative therapy. So the way that we want to manage diabetes is using this blueprint that we learn about, of chronic disease prevention management, which is restoring the metabolism, the regenerative status, the immune, and metabolic. And if we do that, we can have better results in managing diabetes mellitus type 2. So the monotherapy, it's wrong to do it, especially when it comes into chronic diseases or diabetes mellitus in a chronic management of diabetes mellitus. I think it's better to manage it more holistically, integratively, and restoring the metabolic and immune regenerative and metabolic status. Those are the four pillars that we use to manage any chronic disease, including diabetes. And you can see in the picture here, this patient was religiously taking insulin, only insulin, and his hemoglobin A1C is normal. But because of the damaging effect of insulin, as insulin stimulates the NOx enzyme and generate free radicals, the insulin itself is causing the damage. So it's lowering the sugar, which is good, but at the same time, it's causing damage itself because insulin is a free radical generator, by the way. And we will see that also insulin stimulate the mTOR. And what's that mean if you have too much of insulin chronically? That's mean you can put the patient at risk of cancer. So insulin in chronic use, it's not good. And if you want to use insulin, and that's the only resort, in other words, you did every integrative approach that we talked about, restoring the metabolic and immune regenerative of the patient, but still the sugar is high, and you want to add insulin, then, as long as you're adding enough of antioxidant to neutralize those free radicals that insulin is producing, then it's good. Same thing like nitroglycerin, we're giving alpha lipoic acid to prevent the nitric oxide from turning into pyroxenitrate, right? Same thing when we're giving progesterone to antagonize the effect of estrogen. So when you have estrogen dominant syndrome, we give them progesterone because progesterone will antagonize the inflammatory effect of the excess of estrogen. And also it will lead to differentiation versus proliferation. I think Dr. Carroll knows that. So, insulin, estrogen, and nitric oxide, they're all sword with two edges. And once we know and understand how they work and how we can balance it, we can get the best out of them. But if you think, like some doctors, just give them estrogen. Estrogen is the miracle. It's the cure and all that stuff. Or they're giving pellets of testosterone without looking at the conversion of testosterone to estrogen. Those patients end up into estrogen dominancy. Or those patients or people are giving them nitroglycerin without understanding that nitroglycerin, nitric oxide can turn into peroxynitrate and cause damaging, or also, giving insulin without the concentration that insulin is a free radical generator, and we need to give them as much of antioxidant. And also, we need to look at all the underlying inflammation or underlying free radical generators and trying to navigate them. If you have leaky gut, you need to take care of it. You have Lyme disease, you need to eradicate that. If you have the toxins who are free radical generators, those are all free radical generators. All those free radical generators needs to be scanned in the body, needs to be neutralized. So if you have toxins, you need to detox. Leaky gut, you need to manage it. If you have diabetes, you need to manage it. If you have any underlying inflammation, rheumatoid arthritis, anything that may lead to generation of free radicals, inflammation, interleukin 6, all of this needs to be navigated and managed so we can reduce the amount of the patient's insulin. Sometimes you don't need insulin anymore. It's just navigating all those free radical generators. Then you will open up those receptors, because what's happened is that those insulin resistance caused by the inflammation, those free radicals, is blocking those receptors. Oxidized insulin receptors, they don't work. And so if we can open those receptors and increase the sensitivity of insulin by reducing the inflammation and navigating all those free radical generators, then we may not need the insulin anymore. Like this case, when he did the surgery, they said, we don't want to give you any more insulin, just don't take carbohydrate, right? And his sugar is normal. Why the hell they're giving him insulin? Because he wants to eat sweet, so they give him insulin. It's like, okay, well, that can lead to a big disaster and accelerate those cardiovascular disease and stroke. And that's why, in those mainstream medicine hospitals, they're full of stroke and cardiac attack and all that stuff. One of the reasons is just because of mismanaging of metabolic syndrome, because diabetes is part of metabolic syndrome. It's not diabetic type 2. It's not by itself. It's really, most of the time, it's part of metabolic syndrome. We know metabolic syndrome, it's obesity, hyperlipidemia, and diabetes, right? So yes. And I think the mismanagement of metabolic syndrome in general leads to all these problems. And metabolic syndrome is a very high percentage. I mean, if we think about obesity is 60, 70% of the US population, I think it's almost that number of metabolic syndrome, because obesity, most of the time, they have insulin resistance. Because those fat tissue generate interleukin 6. Interleukin 6 will lead to free radical generators and cause an activation of the insulin receptors, and leads to diabetic mellitus. And so if we say 60% of the United States are obese, so we can say maybe almost 50 to 60% of the patients of the United States, they are having some sort of metabolic syndrome. I mean, there's a spectrum there of metabolic syndrome. But we need to manage it. And managing metabolic syndrome, again, it's not just, we need to consider also normalizing the sex hormone. Because if you do that, then you manage the estrogen dominant syndrome. When you manage estrogen dominant syndrome, you manage cortisone dominancy. When you manage cortisone dominancy, you manage metabolic syndrome. Because cortisone itself, when it's high, it can lead to insulin resistance. And it can lead to high sugar, right? The insulin, the cortisone can, when it's high, it can lead to hyperglycemia. And also it can lead to insulin resistance. And so you need to work on navigate everything, restore all this abnormalities, whether it is metabolic, hormonal is considered under metabolic, or immune. So if there's any underlying inflammation, you need to balance that. If there's any abnormal metabolism, needs to restore it back to normal, including hormonal. And if there's any source of free radical generators, leaky gut, toxins on the redox, that needs to be navigated and managed by detoxing and giving them as much of antioxidants. And sometimes we need to give them some sort of regenerative therapies to a healthy one, to regenerate the muscles. And I think Dr. Stefan is very good in growing muscles. And I think that would, at the end of the lecture, you can add more about how we can manage diabetes by increasing the muscle size, because when you increase the muscle size, you increase the number of the insulin receptors. So diabetes mellitus, especially type 2, is no longer merely a disorder of high blood sugar. It's a complex multisystem disease rooted in metabolic inflexibility, oxidative stress, immune dysregulation, and progressive tissue degeneration. So when you have metabolic, diabetes, most of the time is part of metabolic syndrome. And if you see those patients, yes, you will have that they have, inflammation, underlying oxidative stress. They will have immune dysregulation, and yes, they will have degeneration because of those blood vessels being damaged. So no blood flow, no oxygen. So what will happen? You end up with atrophy, and then too much of fat, and a lot of interleukin 6 can be catabolic for the muscles. In addition, if they're not using sugar, right, because of insulin resistance, then the body start eating your own muscles protein, right, to generate energy, and that leads to atrophy. As you see those patient here, I mean, at the age of maybe 65, and see his leg completely atrophy, and that's a combination of insulin monotherapy plus insulin resistance. That's caused by insulinemia. Insulinemia, too much of insulin, can lead to further insulin resistance. So we know insulin therapy is a good thing. It's not a bad thing, especially for acute condition. But when it comes into chronic, we need to understand that insulin itself, or insulin, can lead to oxidative stress, and we need to make sure that we are navigating the oxidative stress by giving the patient anti enough of antioxidants and detoxing the body and screening the body of all the inflammatory sources or metabolic deficiency or source of those free radicals and normalize them. Yeah, I have, I received a text from my group, and one of the doctors said, "Hey, water, longevity from the water structure, whatever they came up with some theory about water. Certain water would help to heal. Yeah, if those water are rich of minerals and hydrogen, they're hydrogen-rich water. Yes, they are a form of antioxidants, and those minerals are magnesium. But they're not going to really. I mean, it can be part as an adjunct and part of the treatment or part of longevity treatment, but it's not everything. You cannot say I'm just drinking hydrogen-rich water and I will slow the aging dramatically without looking at um, uh, all those metabolic imbalance and immune imbalance, and you really need to look at all of this and patch them and navigate those source of inflammation. It cannot be done with one way. It has to be done by really looking at the patient's lab and then trying to restore or normalize those abnormality. That's how you can slow the process of aging and managing the patient. Again, as people will say, just drink this water and you will prolong your life. Or it does help, but it does not mean it's the complete answer. The comprehensive answer, the right answer, is to optimize the metabolism of the body, is to optimize the regenerative status of the body, is optimizing your immune system. And if you do that, you store those four pillars, then yes, then you can slow the process of the aging and slow the process of the. So it's not one way, or it just you really need to look at the patient and diagnose the patient and do the lab and find out what's going on, and then come up with a treatment that will restore any abnormal physiology in the body.
Dr. Halasa, can I ask you a question? Can you describe the biochemistry, how the insulin molecule is causing all these free radicals? My teacher got the Nobel Prize for the bioimmunoassay, person in yellow, of
Right.
insulin. They got a Nobel Prize for that.
Right.
Teach me the chemistry of what it's doing, because you were talking very fast about NOx. What is
Yes,
the
I
insulin
will in
molecule
the coming
doing?
slide.
Oh, I'm sorry.
Yeah, the coming
I
slide,
didn't.
we're gonna break it down. They're coming in the coming slide, all the chemistry in details.
Okay.
And I meant to do that today to make sure that I cover all the chemistry.
Okay.
I'm simply making simple that insulin stimulate the NOx enzyme, the NADH oxidase, when they activate those, when they react with their receptors and they cause insulin influx. At the same time, they activate NOx enzyme, which is NADH oxidase. And NADH oxidase will generate free radicals from oxygen.
Okay. And where is that? Is that located in all the
Inside the
blood vessels?
those are messengers. They will activate the NOx. NOx
Okay.
is enzyme, an enzyme that generate free radicals.
Okay.
So if you have too much of activation of NOx, physiological activation of NOx is a good thing. Physiological level of free radicals is regenerative. It stimulates the antioxidant expression, stimulate all the growth signaling. It's a good thing. But when it comes into chronic and pathologically and high, then it becomes degenerative and inflammatory. And
Okay.
what we have is that patients with insulinemia, because of giving all these injections, they have high insulin and level, which is at the pathological level of signaling of an activation of NOx enzyme. And we're going to see more mechanism that leads to inflammation and free radical generation in the coming slide. But that's the very important part, that insulin itself is a free radical generator. Glucose itself, it's a free radical generator, and it reacts with those free radicals that's being generated from the NOx signaling, and they become glycans and causing more damage. So the more sugar in your body, they react with oxygen, they become glycans, and that's a free radical generator by itself. And it's causing more damaging to the blood vessels and to the endothelial cells, and leads to decrease in nitric oxide and vasoconstriction, and it will trigger the inflammation. So if you have too much of pathological free radicals, will trigger all kind of inflammation, especially Th17. And we're going to see that in the coming slide in detail. So again, diabetes is part of metabolic syndrome, but also there is degeneration and diabetes. There is immune disturbance. There's too much of interleukin-6. That means there's some inflammation, especially Th17 mediated. And all of this will lead to speed the process of the aging. And not just that, insulin also stimulate the mTOR, means that the patient will end up having high risk of having cancer as well. And when you have insulin resistance and you have too much inflammation, as a response, your body starts producing cortisone. Cortisone will aggravate the whole thing and also suppress the immune system, and especially suppressing the immune surveillance against cancer and against viral intracellular pathogens, virus and others. And this will put the patient at risk of cancer and infection. So it's a complex thing. When it comes into diabetics, you would have immune dysregulation, you would have oxidative stress, and then all this inflammation and this vascular damage will lead to ischemia and will lead to degeneration. So you'll have problem with your regeneration as well. So when an acute condition, it's a good thing. You give them insulin, oh, wonderful, right? And it saves life in acute condition. But when it comes into chronic, we try not to give them insulin as much as we can. And if you give insulin, you need to make sure you are navigating all the free radical generators. And navigating free radical generators, not just give them antioxidant, but also looking for all the free radical generators and patch those. Whether those free radicals coming from the Lyme, or coming from leaky gut, or coming from the toxins, or coming from underlying inflammation or lack of sleep, or coming from abnormal sex hormone level. You have too much of estrogen, which leads to estrogen dominancy. All of this needs to be navigated and normalized in order to really restore and optimize the health. So insulin, nitric oxide, estrogen, they have good side and also they have bad side. So we want to make sure we're getting the good out of all of those three molecules. So it's insulin it's a double-edged sword, indispensable for acute glycemic control. There's no question. When you have hyperglycemia, you need to give them insulin. Yet it's counterproductive for long-term healing. Insulin can exacerbate resistance, and it's especially if you have this patient with all this, we remove all this tissue and all this gangrene. If you want them to heal, if you give them insulin, what will happen? You end up with oxidative stress, ischemia. It's not gonna heal very well. That's the reason once we do those surgery, we try not to give them insulin as much as we can, and we ask them not to eat sugar, and their sugar will go normal, and then that's helped the process of the healing. This patient that you saw with this amputation, he has almost 1/3 of his foot. When they told him, hey, just we're not giving insulin, just stop taking sugar, his sugar was normal, right? And so the keto diet is really something healthy, and we need to move to that direction. And is that enough? No, they need to work on normalizing all the aspects that leads to stimulation of regeneration. They need to look at his sex hormone for that patient, which nobody sees his sex hormone in the mainstream as. Any mainstream medicine know that they consider restoring their sex hormone as part of production of nitric oxide and healing and regeneration? No. They need to see if there's any problem with their leaky gut. They want to see if there's any metabolic deficiency, vitamins, minerals. They need to they need to really have some lab work and looking for restoring the whole metabolism, including hormone, back to normal. And some exercise to build up the muscles, and if it takes to give the patient something that helps to build up the muscle, it's very important as well. As Dr. Stefan will come and say, well, just building the muscle itself will generate a lot of insulin receptors, and it will help in weaning patients from the insulin. It helps the healing part, whether you're doing it with exercise or with some medication. That Dr. Stefan is very expertise in that. Then yeah, we need to really increase their muscle bulk. As you see, the patient is completely atrophy. And part of the atrophy, it's because of the lipogenesis that's caused by the insulin. And we know the lipid, fat tissue, especially the visceral fat, generate inflammatory cytokines that cause muscle wasting, especially interleukin-6. So insulin itself, it will exacerbate resistance because it will induce free radicals, and those free radicals will oxidize, rusting the insulin receptors, and it will definitely make them insensitive, right? And decrease their number. And eventually this will lead to worsening the inflammation. So the root mechanism of diabetes mellitus, insulin stimulate NOx enzyme, natural oxidase. We need free radical, but we need it in the physiological level to stimulate your expression of antioxidants and growth factors. Yes, and anti-inflammatory cytokines. You need that spark of free radicals that leads to that. That's why we exercise. Exercise is generating free radicals, but physiological level. But if you do too much of exercise and it's becoming pathological, then you end up with muscle atrophy. So at a certain time, if you do more of exercise, you're not building muscle, you're destroying muscles. I think Dr. Stefan will relate to that very well. So diabetes mellitus is not just a disease of high blood sugar. It represents deeper system breakdown involves. So let's go ahead involving this. Chronic insulin exposure leads to activation of NASH, which is NOx enzyme, leads to increased oxygen species, right, which is reactive oxygen species, which is pathological, leads to oxidative damage, especially to the cytoskeleton, right, including the insulin receptors. It leads to block the glutamate, the GLUT4, which is the glucose transporters, right? And it prevents them from uptaking the sugar because of the oxidation. It's like it's causing insulin resistance because it's blocking those receptors that takes the sugar in. And this will lead to worse insulin resistance. Then you have more sugar, you need more insulin and more insulin, more insulin, more inflammation, more insulin resistance, and more oxidative damage, more accumulation of NOx, more inflammation, damage in the endothelium, lowering the nitric oxide, vasoconstriction, and ischemia, and all the problems that we see with patients with diabetes. So the key pathological effect, the actin cytoskeleton damage of the cells itself will get damaged, oxidized, and this will prevent, because it's the dynamic protein that causes the transportation of sugar will be compromised, as you see it here, and the sugar cannot go in, more sugar is out, more insulin you need to lower those sugar, right? And more insulin resistance, you end up with vicious circle of needing the same, like, patients who are taking dopamine narcotics, right? Narcotic itself, it stimulate the Mia receptors, and it causes the analgesic, but at the same time, when you stimulate the Mia receptors, it leads to signaling of free radicals, especially opening up the calcium channel. The calcium channel will lead to activation of NOx, and then you end up with a lot of free radicals that will block the Mia receptors, and the Mia receptors will not work anymore, so the patient needs more of narcotics. So the narcotics is similar, same thing. If you see the concept of the mechanism, that narcotic it gives you analgesia, yes, by stimulating Hrs receptors, but at the same time, and open up the potassium channel, but also it will signal free radicals by stimulating NOx enzyme that leads to blocking of those Hrs receptors. And that's why you need more narcotics. All right. And insulin does the same thing. So there's a pattern there. I think Dr. Joseph likes the pattern thing. So here we go, that insulin signaling blockade. And this leads to, more of reactive oxygen species. And this will degrade the insulin receptors, right? And when you have too much of free radicals, it will damage the mitochondria as well. And when you damage the mitochondria, you will lead to more of free radicals released from the mitochondria. And you will end up, when you disrupt this electron transport chain, you have a problem with the production of ATP. And when you have too much of free radicals, you activate the NFK beta, which generate more free radicals, right? And this will stimulate also the interleukin-6 in inflammation, because those pathological free radicals, we know it stimulates NFK beta, and then it stimulates, and those NFK beta will signal and increase the inflammatory cytokines, especially interleukin-6, and you will end up with inflammation, especially Th17 type of inflammation. And when you have too much inflammation in the gut, you destroy those tight junctions between the epithelium and you make them leaky. What will happen? You end up with leakage of those toxins of the bacteria into the lipopolysaccharides to those gut epithelium, because the damage, inflammation, too much of active Th17 can lead to damage of those tight junctions, and your gut will become leaky and release into toxins. The toxins in the blood will lead to more free radicals, and the more free radicals will cause more insulin resistance, because it will oxidize those insulin, make them insensitive, right? And and this will lead to further activation of NOx, further activation, inflammation, and you end up with a vicious circle. In addition to that, those insulin stimulate lipogenesis, fat. What will happen when you have too much of fat, especially the visceral fat? You end up with a lot of inflammation. Those fat can be source of inflammation, interleukin-6. And so it's all going into direction of inflammation, degeneration, immune imbalance, imbalance in the redox status. So this excess of insulin without restoring the redox balance is the problem. So once you want to give insulin, you need to make sure you are managing the redox. You're giving enough of antioxidant, you're detoxing the body, you're looking for all sorts of inflammation, you're fixing the leaky gut, you are killing the Lyme disease, right? Or any hidden infection. So you need to really screen the patient. It's an active process. You're not saying, oh, just give them this miracle water and it will heal, or give them just red light and that's it. I mean, all this will help. They are antioxidants, but they're not going to be enough to really optimize the health. They are part. Yes, it's like you have a tire with many holes, and you say, I'm going to fix the hole or fix the tire by just patching one hole. Yeah, but what about other holes? In order to fix the tire, you need to patch all the holes. But in order to fix the whole holes, you need to, first of all, to find them. You need to search for them and find them and then patch them. But the idea that you can fix the tire just by patching one hole, this is what's happening to most of what's going on, whether the mainstream medicine or even integrative doctors they're happy with one way. And, once people, they say insulin, just give them light, or give them miracle water, hydrogen-rich water, or give them electromagnetic waves and they will heal. And yeah, just patching. You're patching one of the holes. I'm not saying that it's not going to work, but you really need to work and investigating and looking for all those sources of free radical inflammation, of this metabolic disorder, where they are, and then work around it and start building and optimizing the patient's health. So excess insulin without restoring redox balance fuels the problem, right? Especially, I have one of my relatives, he's my uncle, he said, I used to take metformin, but metformin make me lose weight. So I switched to insulin, and he takes insulin plus he's taking sugar, right? So it's exactly like putting gas in the fire, because more sugar, more insulin. Insulin is a free radical generator to signal the free radicals, and then this will oxidize the glucose that he's taking, the sugar that he's taking, become glycans, and glycans are free radical generators that will damage all the endothelial cells and decrease the nitric oxide, and they end up with ischemic heart attack, stroke. And yes, that's what happened. He ended up with ischemic heart problems, or those patients will end up with angina, stroke, or peripheral vascular disease to the point they end up with gangrene. So the reversal of diabetes requires redox restoration, antioxidants, NOx inhibitors. It requires mitochondrial repair, energy support, giving them all the supplements that helps to rejuvenate, or in other words, to restore the mitochondria, like, QQ10, alpha lipoic acid, and things that we're doing, the thiols. Managing leaky gut syndrome, give them the gut, probiotic and prebiotic and postbiotics, and sometimes gut microbiota in case that they need it, to repair the barrier that we talked about. Inflammation leads to disruption of the barrier, leading to leaky gut syndrome. And so we need to give them all these anti-inflammatory strategies, and this will stabilize the cytoskeleton that's being damaged by the free radicals, and maybe those transporters of the sugar will start working and getting the sugar in after all of this. And so the diabetes is the redox cytoskeleton mitochondrial collapse. Those free radicals damage the cytoskeleton, damage the mitochondria. They cause more release of calcium from the storage, which is from the endoplasmic reticulum. When the calcium goes influx into the mitochondria, generating more free radicals, you end up with a storm of free radicals and inflammation and damaging the mitochondria and cytoskeleton. It's all oxidized, rusted, because of insulin, right? And this collapse, not just a sugar problem, but it's also insulin-induced NOx activation, is the hidden driver of the metabolic failure. So now we understand that insulin is good if you give them for acute conditions, just lowering the sugar. But when you give it chronically, you need to be aware that it's a sword with two edges. It can lead to damage. It's a free radical generator itself. Even if you see their hemoglobin 1 C, it's good. So you're good. Oh, wonderful. Go home. Your hemoglobin 1, and he's and his blood vessels is being messed up, degenerated, because of that insulin that the patient is being received from that doctor. It's a iatrogenic problem, by the way. And this is because of the lack of the system knowledge that insulin by itself, it could be detrimental for the patient. And they need to understand that the insulin is a sword with two edges. And today we know. So all of you here, you need to spread the information, the good news. And also when you have patients coming from the mainstream medicine, you can explain to them, hey, those insulin, if you take it by itself without navigating all those sorts of inflammation and free radicals, the insulin itself can accelerate and cause stroke and heart attack. And even if your hemoglobin A1C is normal, does not mean that you're slowing. Actually, you're accelerating the whole process of the degeneration and angiopathy and neuropathy just by giving insulin. So hemoglobin A1C is not enough as a monitor for health optimization. So what we want to do, we need to do endothelial function test. That's very, very important. More important than hemoglobin A1C, by the way. So we still need to do hemoglobin A1C to see the patient's sugar. If it's high, that's mean you have too much of glycans. So we need to do it, yes, but also you need to do endothelial function test. And if the endothelial function test is bad, and that's what's happening with patients taking insulin by itself, it gets worse and worse and worse. Then you're not really helping the patient. You are actually causing damage to the patient. So how insulin works? It activates this phosphoinositide kinase enzyme, which activate the mTOR, by the way. And activating the mTOR means that you're stimulating the growth and proliferation. It's not good, especially when it comes into retinal angiopathy. That's happening with patients with diabetic, and they lose their sight because of the stimulation, excessive stimulation of the mTOR and the vascular endothelial growth factors. And those blood vessels, they're not normal blood vessels. They're kinky and abnormal. Um, and so activation of this kinase will promote the glucose transporters, which is a good thing. This is a good thing. Okay, so it activated. It leads to shuttling of the sugar inside, which is good. Translocation of glucose uptake. That's what we need. The problem is is when they start activating too much of NOx enzyme. So shuttling of the sugar inside the cell, that's what insulin does. That's a good thing. But what the bad side, it's actually activating the NOx enzyme. That's the bad side. Same like narcotics. They stimulate the Mie receptors, which will open up potassium channel, which leads to hyperpolarization of the pain neurons and give you that numbing of the pain. But at the same time, they open up calcium channel. Calcium influx leads to activation of NOx enzyme, generating free radicals, and then those free radicals will block those Mie receptors, leading to insensitivity to narcotics, and the patient needs no more narcotics. So the same concept here with insulin. Insulin, open up, leads to glucose entry, that's good. But at the same time, it activates the NOx enzyme, and that's not a good thing. And also, it stimulates the mTOR, and it stimulates the MAP, which is mitogen activated protein kinase, and that activates the mTOR. And too much of excessive activation of mTOR and increasing the insulin growth factors, all this leads to too much of proliferation, which can put the patient at risk of cancer as well. And it leads to lipogenesis. Oh, that's not good, right? Because too much of fat leads to inflammation, and it leads to glycogen synthesis, and it leads to protein anabolism. Okay, that's what we want with insulin. So it's good that it leads to protein anabolism, but the problem when you do have too much of fat in the body, the fat will release cytokines, inflammatory cytokines, which leads to muscle wasting. So it's antagonized at the end with lipogenesis. Lipogenesis leads to too much of fat. Fat leads to interleukin-6, and interleukin-6 will lead to muscular atrophy. Although insulin itself, it's good for protein anabolism, that's true. You may consider that. But if you have too much of it chronically, and you have a lot of lipogenesis, and also you end up with too much of free radicals, it may lead to muscle catabolism. And then it leads to insulin insensitivity at the end. And when you have insulin insensitivity, then the body needs to get energy. So where are they going to get it? They're going to break down the muscles. Protein is a source of energy. This is what's happened when you take chronic. So this is a good part if you're giving it in acute. This is what we want. Okay, but if it's too much, then you end up with a reverse. The therapeutic paradox, short term. Okay, Shell, do you need something? You're texting me. Sheldon. Are you there, guys? Can you hear me, guys? Okay, good. Sheldon is calling me. I don't know why. Okay, so the therapeutic paradox, short term.
Okay, can I ask one thing again, Dr.
Yes,
Halasa?
please, go ahead.
You're talking about every fat patient who has high insulin. The first thing I measure on every patient is their blood insulin. And so they're, it should be around, below 5? Now, they're having the same terrible physiology. Am I correct? Let's say they have a fasting insulin at 25.
Right. If the patient is taking too much of insulin is very high,
Or making the insulin, not taking insulin.
or
I'm talking
even
about patients.
if you have insulin resistant and you as a response you have too much of insulin in your body circulating, yes, it's horrible. It can lead to immune dysregulation, as you saw there. It can lead to more insulin resistance, as you saw, generate too much of free radicals. And it leads to lipogenesis, too much of fat. The fat will start increasing inflammatory cytokines, and those causing muscle wasting. So it will the good part of whatever insulin is doing, it's gonna be reversed. Same like nitric oxide, same like estrogen. Too much
Right.
of it in a bad environment, they can become detrimental. Same thing like narcotics as well.
Right, but I'm talking about patients, they're doing it naturally. They're not taking insulin. They're making insulin. That's the
Yes, if they
problem.
have insulin, if they are fat, if they eating too much and have too much of fat,
Right, right.
right? So they have
Yes.
this releasing of inflammation and interleukin 6, and they are oxidative stressed because of the leaky gut, because of the fat tissue can be source of inflammation, free radicals, toxins that the fat tissue stores, right? And those fat tissue generate estrogen. Estrogen leads to estrogen dominancy, and estrogen dominancy itself leads to cortisone dominancy. Yes, you end up with too much of free radicals, and this inflammation and insulin resistance will demand more insulin, right? As a response.
Mhm. Yeah.
And more
Oh.
insulin will lead to more insulin resistance and lead to all the crazy things that we see here. They end up with a vicious circle of deterioration, as you see it here.
Sure. Interesting. Thank you.
Right. So the therapeutic paradox here, short term is good. We need it when we have somebody with diabetic, high sugar. You give them a lower sugar, right? We use it also for treating hyperkalemia, especially patient with cancer, and we give them chemotherapy. Their potassium goes up. They end up with cardiac arrhythmia. We give them insulin sugar to lower that potassium. We need insulin. I'm not saying insulin is a bad guy, but it needs to be given in a more smart way, right? And understanding it's a sword with two edges. Too much of it is not good. Normal is good. Same like nitric oxide. Too much of it, it's not good. Normal, it's good. Estrogen, same thing, right? So it reduce hyperglycemia, yes. It prevent diabetic ketoacidosis. It stabilize critical patients. So it's a miracle molecule. We like it. But long term promotes lipogenesis. And lipogenesis, too much of fat means cytokine. Inflammatory cytokines means interleukin 6. Interleukin 6 means Th17 inflammation, means free radicals, means muscle atrophy, means more insulin resistance, means oxidation of insulin receptors, means damaging degeneration, right? Although insulin, its signal in the beginning, its signal anabolism, right? It's anabolic molecule. That's why people trying to build muscles, they're taking sometimes insulin shot. Yes, for shots of insulin, because those free radicals that they generate insulin, and if it's short and like a spark, they actually stimulate the anti-inflammatory and antioxidants expression and growth factor and muscle growth. But if it's long and you have too much of free radical, high, constant, then it becomes detrimental. It reverse. Everything will go in the opposite direction. Same like exercise. Exercising generates spark of free radicals that you need to build up your muscle, because those spark of free radicals will stimulate the expression of anti-inflammatory and growth factors and all the good healthy things. But when you do too much, not good. You may end up reversing from building muscles into atrophy. Same thing with insulin. And because the insulin stimulates the mTOR, which will lead to increase the insulin growth factors, like growth factors, this can put the patient at risk of cancer. Think about it. You have proliferation, and then you have inflammation. Oh, you don't want inflammation and proliferation together. This is not good. This leads to cancer. Plus, with insulin resistance, as we said, it can lead to estrogen dominancy. It can lead to cortisone dominancy. Too much of cortisone as responsive inflammation caused by insulin resistance. It can lead to suppression of the Th1 immune surveillance, because your inflammation is more moving to Th17. Cortisone suppress more more Th1 versus Th17. And when you suppress the Th1, then you put the patient at risk of cancer and infections in general. So it's not good all the way. So dose insulin is both life-saving and potentially disease-propagating when not coupled with deeper metabolic correction. I hope we learned something today that we can carry this message to many of medical centers out there to rectify what's going on, because what's going on is a disaster. And the number of heart stroke and all this, it could be, we are, as a doctor, be part of it. It's the same thing with pain management doctors. They are good in helping the pain, yes, but at the same time, if they are doing too much of this narcotics, those pain clinics can be source of pain, not treating pain. And those patients, they will look like zombies, all they think, because their brain is completely wired just to seek and getting those narcotics because of the oxidative stress that's caused and inflammation that's caused by the narcotics that leads to immunoreceptor insensitivity. Same thing with patients with diabetic. If they are relying on insulin only, that leads to oxidative stress, and they end up with this vicious circle of inflammation and insulin insensitivity and the whole complications of diabetes. So those endocrinologist centers, if they are relying on insulin monotherapy and managing diabetes, especially type 2 only, they can be a source of damaging to the patient, of accelerating the complication of diabetes. They can justify it. They say, well, the hemoglobin A1C is normal. Yeah, you lower the sugar, but you end up with insulinemia. And insulinemia is as bad as with high sugar. They're both free radical generators, and maybe even worse. So hemoglobin A1C is a good thing. Yes, we need to put it on account in monitoring the patient with diabetes, but you also need to check your endothelial function test. That's very important. And if there's both normal endothelial function and the hemoglobin 1C, that's moving in the right direction. But if your hemoglobin 1C is normal and you having a severe bad endothelial function test, that's mean you're on the wrong track and you're causing more damage to the patient. Okay. So what is the complication that the hidden cost of insulin generic management and systemic complication? You will end up with burning those blood vessels, microvascular complication, myocardial infarction, right? Because of those are the free radicals insulin resistance that cause inflammation, and all this free radical insulin is producing is damaging those blood vessels, causing this ischemia, myocardial infarction, stroke, atherosclerosis, damaging the blood vessels, will accumulate those fat and lipid plaques and all that stuff, worsened by insulin-induced dyslipidemia, and endothelial dysfunction. So insulin, too much of it, yeah, you will end up with dyslipidemia, and you will end up with endothelial dysfunction. What else? Microvascular complications, retinopathy, right? You will end up with too much of VEGF-driven neovascularization and oxidative damage, right? So that's not good, right? Those blood vessels are abnormal growth of blood vessels, which we talked, it's not normal, and inside the retina, and they will obscure the light from passing through. You need to have a clear vitreous. But when your blood vessels of the retina start growing inside the vitreous, and you have blood vessels in the vitreous or in the retina, it will prevent the light from reaching out to the retina, and the patient ends up with blindness. Neuropathy, or nephropathy. Those damage in the blood vessels due to insulin resistance and inflammation, oxidative stress that's induced by the insulin. It can lead to glomerular fibrosis. It leads to mitochondrial dysfunction, and you end up with kidney failure, right? Neuropathy, axonal degeneration, because all the blood vessels is being damaged. Those supply those nerves, and you end up with axonal degeneration and nitric oxide depletion. And at the end of the day, the patients will start losing the feelings of his extremities. And we know the distribution is called the gloves, shoes, or socks, anesthesia, or numbness and tingling in the gloves, socks distribution, right? So those are neuropathy, and they don't feel anymore, and they start injuring themselves. And with angiopathy, and there's no much of blood flow, there's no much of regeneration, become abnormal. They end up with infection because their immune system is being compromised. As we know, those free radical generators leads to too much of Th17 inflammation abnormally, and the patient will be having risk of infection and gangrene and amputation and all the problem that we experience with the complication of diabetes. So it's a complex thing. It's not anymore, just low sugar or high sugar, the diabetes. No, you can see it's affecting the immune system. It's affecting the redox, and it's affecting the metabolic, and it's affecting the regenerative status of the patient. And that's why we need to work on those 4 pillars when we manage patient with diabetes mellitus. So metabolic degeneration or derangement, right? You will end up with obesity. You will end up with fatty liver disease. You will end up with hypoglycemic episodes, especially if they're taking it, and end up with hypoglycemia and syncope and all that stuff. You will end up with cognitive decline and autoimmune dysfunction because of all this ischemia that's happening. Your autonomic nervous system will not function anymore. Your brain will not function because you're not getting enough of oxygen and nutrition going to your brain. So definitely the cognitive and autonomic dysfunction will be part of the manifestation of diabetes mellitus. Now, this is very important, which most of the doctors here may not hear about it before, and myself. I mean, that insulin, because it stimulates the mTOR and stimulating the insulin growth factor, this will lead to proliferation. And we know proliferation inflammation means what? It means putting the patient at risk of cancer, especially the inflammation, talking about the Th17 inflammation that will drain the immune system and drain the Th1 inflammation or immune response or immune surveillance because you're busy, producing unwanted inflammation. And you will be depleting the immune surveillance, which is Th1, against the cancer. And you put the patient, at risk of cancer because you have something that stimulates them, which is insulin, and stimulate the proliferation uncontrollable, those cancers that's emerging, and you're suppressing the immune system that destroy them or watch them, and you end up with cancer. Okay. So the systemic biological blueprint, the way that we need to manage any chronic disease, and this is something we learned from CDPM, chronic disease prevention and management. The blueprint is to look at those 4 things all the time. And imagine, not just diabetes, for any disease, chronic disease out there, you need to look at those 4 pillars. Immune, metabolic, and metabolic include hormones, by the way. Immune, metabolic, regenerative, and redox. And once you screen the abnormality in those 4 pillars, and you start working on restoring it and normalizing it. This is the only way, really, we can slow the process of manage chronic disease, and the only way that we can slow the process of the aging. The idea about, just one pill will help in managing and slowing the process of the aging, it's not realistic anymore. So it needs to be actively investigating, looking for all those pit holes, and normalize them. So the truly reversible diabetes, we must restore the biological network, not just the blood sugar, right? It's not just the blood sugar, but we need to restore the whole 4 pillars that we talked about, because they can contribute in insulin resistance. If you have Lyme disease, you have inflammation, you have oxidation of those insulin receptors, so they will not work, right? You end up with insulinemia. Or you have toxins, or you have underlying Crohn's disease or rheumatoid arthritis, or you have leaky gut, or you have sex hormone imbalance, or you have vitamin D deficiency, or any vitamins or mineral deficiency. So you need to really screen and normalize all of this, because all of this, you have obesity, too much of fat, which could be source of inflammation as well. You need to look at all of those abnormalities, all of those, and you take a comprehensive history and physical exam to look up all those insults, whether it's coming from outside or from inside. Could be environmental, could be from stress from the work, stress from his spouse, stress of lack of money. All of this needs to be considered when you are managing chronic disease. And that's why American Medical Association, they came up with a group called CDPM, and they come up with, they're asking us to develop residency fellowship program for making sure that when they are managing the patient, they need to be more comprehensive, including all those biophysical factors that may contribute in aggravating or triggering of those chronic diseases. So the specialists, most of the time, they do fail in managing chronic disease because they are being trained to this kind of narrow scope, only the system. I'm a neurologist, I only fix nervous system. But yes, but if you have a problem with your gut, leaky gut, or you have endocrine problem, diabetes, or you have infection, or you have ischemia somewhere, you cardiovascular problem, or you have problem with your lung, all of this can affect, because all this could be source of free radicals, can affect the disease that you're treating, like treating Alzheimer, or you're treating Parkinson. If you don't fix all those problems, you're not going to fix the Alzheimer or Parkinson disease progression. But those neurologists say, oh, man, I don't care, I just give them L-dopa, and that's it. Well, L-dopa will turn into quinins, and quinin cause, it's a free radical generation, will cause more degeneration of the dopaminergic neurons. So really, you may be helping them for short term, making them feel good and moving, but at the same time, you're speeding the process of degeneration of their dopaminergic neurons. So how you can be better than neurologists? It's not just enough to give L-dopa. You need to look for all those free radical generators and manage them. And that's the difference between integrative doctors, chronic disease prevention management specialists, from the specialists. And I think RFK is one of his agenda and mission, and his is to he's focusing on chronic disease, how we can manage chronic disease, and we need to have a medical board specialty for this field. So after they become neurologists, they may need to have kind of a residency, and then they have a board specialty for a special disease or a special system, right? Neurologist, cardiologist, but they may need to have another level of training, which is called chronic disease prevention management, which under that, it's the integrative and regenerative and holistic, all that. It can be clumped together under a big field of CDPM, chronic disease prevention management. So we need to see the problems of oxidative stress, damaging the insulin receptors and the B cells because of this oxidative stress, and we need to navigate those sources of free radicals and find them. Same like a tire with many holes. You cannot just say, I'm going to fix one hole and I can fix the tire. And you need to really, first of all, find those holes and then patch them all. And that's how you can manage, or you can fix the tire. Same thing in chronic disease. So the therapies will be NAC, supplement of antioxidants help to replenish the glutathione and detoxify the cells. Alpha lipoic acid will be a good thing too. What else you want to give? You want to give polyphenols, right? You want to, alpha lipoic acid also helps to increase insulin sensitivity, because once you neutralize those free radicals, you open up those insulin receptors. You want to give them molecular hydrogen. Yeah, rich water or hydrogen-rich water will be good, because hydrogen, it's an antioxidant, neutralize those free radicals, especially those hydroxide radicals. Ozone therapy, works two way. One, it get rid from those superoxide free radicals because those are more oxidative. They have higher redox potential than ozone. So they work as an antioxidant there for clearing the superoxide radicals, but also they are a free radical generator as well, but it's not as powerful as superoxide radicals. So they may help in as a spark of free radicals to stimulate the antioxidant expression, which is the enzymes. And photobiomodulation, light therapy, we know they are antioxidants by many way of their mechanism, including releasing the nitric oxide and activating the mitochondria, because mitochondria get blocked with nitric oxide. So light helps to unblock them, increase the activity of electron transport chain, and releasing the nitric oxide from the cytochrome oxidase. So it's basically activating the mitochondria there. Once you activate the mitochondria, then you can help in restoring the redox, right? And prevent those leakage of those free radicals from the mitochondria or going inside. So managing light therapy helps to activate the mitochondria, and it helps to clear all those free radicals. Plus, when you have a healthy mitochondria, you can burn those sugar all the way down, and it does definitely help to, you know, empower the antioxidants efficacy. And it will help to improve the glucose metabolism, right? When you burn those sugar, you get rid from them. Anything that helps to burn the sugar, you get rid from them. That's part of decreasing those sugar, which are free radical generator, by the way. Glucose is a free radical generator. And when you activate the mitochondria, you are burning them. So that's a good thing. So exercise, light therapy, all of this leads to enhance the mitochondria and burn those sugar and increase the insulin sensitivity ultimately. The other thing is metabolic reprogramming and restoring the energy pathway. So the problem with diabetes, diabetic cells rely on glycolysis and fat storage, right? So the therapy here, we need to consider AMPK activate protein kinase, right? Then those activators like metformin and berberine. So those will help to promote energy efficiency and autophagy because they will stimulate the AMPK. And we need that, right? In order to activate those mitochondria and induce mitophagy and getting rid from the inflammasomes, because the inflammasomes, which those cells that contain inflammasomes, that can be source of interleukin-6. And you want to get rid from those inflammasomes because those interleukin-6 is causing the free radicals. It's activating the NFK beta, and it's causing more free radicals and insulin resistance. So we want to get rid from those inflammasomes containing cells, then get rid from them by activating the AMPK. And AMPK will activate the autophagy of those inflammasomes. All right. And also, you may need to empower the mitochondria as well. And when you empower the mitochondria, especially inside the bad cells, you may induce mitophagy and kill that cells. Or when you empower the mitochondria in those cells, you end up burning more of the sugar, reducing the sugar burden, reducing the free radicals, and reducing the amount of insulin you need. Because what bumps the insulin, what stimulates insulin, is the high level of sugar. Your beta cells sensitize that you have high blood sugar, they start secreting insulin. So if you lower anything that lowers the sugar, will lower the insulin. And that's the whole purpose there. So what we need to do is to activate the mitochondria to burn those sugar and get rid from it so we can lower the insulin level, and then that will lead to improve the insulin sensitivity. And also doing this, you get rid from the inflammasome, you get rid from source of those free radical generators, you get rid from oxidizing the insulin receptors, you increase the insulin sensitivity. So you need to give them all of that. And possibly you need to give them GLP-1. That's a good thing, right? Helps to certain way reduce appetite. and it does help to increase the insulin sensitivity by doing it, right? And so it supports the satiety, right? And so you don't need to don't crave sugar and you don't eat too much of sugar. That's one way of managing. And when you lower the calories and all of that, you activate the AMPK. We know the lower sugar in the body means activation of AMPK. Activation of AMPK means activation of the autophagy and getting rid from the inflammasome, senescent cells, and cancer cells, because all the cells can be source of free radicals as well, whether cancer cells or inflammasomes containing cells or senescent cells. All of this can be source of inflammation and free radicals and leading to insulin sensitivity. And when you giving GLP-1 and you're reducing the appetite, reducing the amount of sugar you're taking or food you're taking, definitely this will lead to shrinking of the fat tissue, because fat itself is a source of free radicals. Fat tissue secretes interleukin-6. It's inflammatory tissue. And interleukin-6, we know, in addition to increase the free radicals, interleukin-6 stimulated Th17 inflammation, which will drain the immune surveillance of the Th1, which will put the patient at risk of cancer. So anybody who's obese, he's having high risk of cancer, by the way. Why? Because those fat tissue releases interleukin-6 and cause inflammation, unwanted inflammation, which Th17 overactivities, which will drain the immune system from surveillance against the cancer and against the infection. So getting it from the fat tissue is very important. I think in Japan, they are doing this program, by the way. Japan is more advanced than any other countries. They are fining people who are obese by they pay tax or something extra. There's a fine if you're obese and overweight. You end up having less chance to have a job. Plus, you may end up paying fine for being obese. may need that in the United States. We need to really follow the Japanese thing. Maybe that helps to decrease the problem that we have and of obesity, and this will help to really improve the economy as well. Because if you're able to put more energy, invest in prevention, like what Japan is doing, then you don't get enough of sick people. Then you spend less money in reversing those disease and those end stage of those, which is very, very expensive. So very important to know that when you have diabetes, it's not just a problem with redox, or it also problem with the immune. You will have chronic inflammation, and all this, either insulin resistance lead to inflammation, and inflammation aggravates the insulin resistance. So it's kind of both way. And this inflammation causes more damage to the tissue and degeneration. So how we can manage that? You give them anti-inflammatories, the supplements, not although you may need to give low dose aspirin if the patient has, if the patient has history of stroke or angina, you want to lower the platelets activities that's being active due to atherosclerosis. Yeah, but we're talking about supplement anti-inflammatory. That's really inhibiting the Th17. Those supplements inhibit the Th17. That's what exactly the problem is, the overactive Th17 in diabetes because of interleukin-6 induced. And so what you give them? You give them curcumin, you give them resveratrol, give them polyphenols. All of this will have the NFK, beta, and pro-inflammatory cytokines. You may give them low-dose naltrexone. Yes, that will help as well to inhibit the Th17 and modulate the microglia. Yeah, you may end up giving them the prebiotic and probiotic to manage any leaky gut syndrome, to repair gut repair and balance the immune tone. You look at any metabolic deficiency, vitamin D, it's very important. Omega-3, those immune modulators that specifically target Th17, not cortisone, which suppress the whole thing. You don't want that. You want something that suppress mainly TH17. Cortisone suppresses everything and all kind of inflammation, but specifically the TH1, which that's not something you want. You want something that suppresses the TH17 specifically and mildly, not suppressing it too much, but suppressing it in a natural way. And I think the vitamin B12 and the polyphenols and thiols and things that we naturally that can be handled by your biological system, because all the synthetic drugs, the problem is that they're not biological friendly. You know, when they get metabolized or breaking down, they may end up with toxic metabolites. While all these natural products that we're receiving, their metabolites are not toxic. So when you break them down, it's easy to get rid from them without causing any harm. So giving them basically those anti-inflammatory, those supplements that we then you may consider a regenerative and repair therapy, building lost tissues. As we know, the diabetes, because of all the problem that they cause, the vascular problem and the ischemia, degeneration, inflammation, and degeneration, right? So you need to go ahead, possibly giving them something that helps to stimulate the regeneration. But after you activate the AMPK, after you inhibit the mTOR, by fasting or giving rapamycin or fasting, I like fasting, or by giving polyphenols, you need to make sure you clear the body from inflammasome and senescent cells and cancer cells first. You need to clear the body from the weeds by fasting and all those mTOR inhibitors, and then you cycle it with mTOR stimulators. That's fine. But you don't give mTOR stimulators, those growth factors, before that. That's very important. Giving BPC is a good thing. It really inhibit TH17, and also it may induce some regeneration effect. Giving the GHK copper, yes, that's a good thing too. It may stimulate repair, normalizing that genesis. Exosomes, you may need it for patients who are inflamed and degenerated, to regenerate the cells. Yeah, I will give that. Rebuild some B cells possibly, and reversing those neurons. What other thing that Dr. Joseph likes to give? Clotho. It's a good thing, especially a patient with neuropathy. You give them Clotho. You give them also angiotensin, what we call the ARB, low dose losartan will be good too for those patients. You may need to give them oxygen, right? Because they have ischemia due to all this oxidative damage in the blood vessels. So maybe the oxygen will help in activating the mitochondria and regenerate, and empower the immune system in getting rid from all this infection that may aggravating the problem. Cold plasma electrons that may neutralize the free radicals. They work like an antioxidants. And they may combat infections and promote wound regeneration. Yes, those electrons, they are very powerful. That's from cold plasma. They're antioxidants. They neutralize the free radicals, excessive ones, the pathological ones, and that possibly leads to stimulation of the regeneration. Those complications of diabetes that we know, with the retinopathy, we use ECGC, photobiomodulation, all of these peptides may help. Nephropathy, we give them NAC, we give them low dose losartan, berberine, stem cells, Clotho. Neuropathy, right? We give them alpha-lipoic acid peptides, photobiomodulation, low dose neuropathy. Wound, we may give them cold plasma, which is electrons. We may give them platelets, ozone, methionine blue, mix it with nitroglycerin, especially if you have gangrene. I think Dr. Quinn used to do a lot of that when we worked together before. We are doing a lot of nitroglycerin, alpha-lipoic acid, and we can mix it with methionine blue, and we put it, and then we shine the light. You can get rid from all those bad infection that resistance to antibiotics. It's nothing powerful, than this gel of mix of nitroglycerin, methionine blue, and alpha lipoic acid. You mix it together as a cream, as a gel. You put it on those diabetic wound or even bedridden ulcers, and you shine red light. You get rid from all those bacteria and biofilm that's resistant to antibiotics. There's nothing powerful than nitroglycerin and methionine blue and light therapy, which is photodynamic. Those nitroxides from nitroglycerin are very powerful because they react with those free radicals of the bacteria, the bugs, and blow them up. Nitroglycerin can blow up infections and bacteria. In addition to nitroxide, which helps the healing and regeneration and improving the endothelial function, but also it can turn into peroxynitrates and kill the infections. Like very powerful. So I have a patient that I remember. She is amputated and she's wearing those prosthetic. The prosthetic leads to all this rubbing of her skin and bone, and led to some sort of a wound that led to access of infection to her bones. Okay, so they want to really. She's amputated below the knee, so the tibia is been cut just below the knee. But it's a good thing to keep that joint so she can walk with the prosthesis. But now because that little piece of the tibia on the knee joint, it's infected, they want to remove it. And I say, no, we can save it. And I did save it just by putting cream or gel of nitroglycerin, methylene blue, and alpha lipoic acid mixed together. Dr. Quinn used to do them for us, and then shine the red light on it, and that would help to clear those osteomyelitis infection caused by staphylococcus that gets deep into the bones. There's nothing better than that. If you really want to get rid from the osteomyelitis similar to those conditions of gangrene, you mix those cream together. So again, omega-3, CoQ10, all those antioxidants will be good. Cognitive decline, ketogenic therapy, NAD, clotho, intranasal, insulin instead of giving them IV, possibly shots. What else you give to those patients? Sarcopenic obesity. Obesity can lead to sarcopenia because fat release interleukin 6 and anti-inflammatory cytokines that leads to muscle wasting, and possibly we need to give them some medication that helps to boost the muscles. And I think Dr. Stefan will be some peptides and androlone and things like that helps to increase the bulk of the muscles. Doing that helps because when you increase the bulk of the muscles, you increase the number of the receptors. Ozonated glycerine, yes. Well, that's a good one. But I like to load ozone with platelets nanoparticle. So that's more natural. So you take the platelets and then you sonicate it. And during the sonication, you can bubble it with oxygen. Or after you do the platelets and you can load it with ozone. And you can get better results even from glycine because it's more natural. So your platelets, nanoparticle, sonication with ozone, you bubble it with ozone, you can load the platelets with ozone, and I think it can, and then you give it IV. That's one way of getting the oxygen into those tissues that's been compromised because of the angiopathy. And the angiopathy, they become so small, or they will not even allow the red blood cells to pass through. Same like cancer, you know what happened? And you can bypass that with platelets nanoparticle load with ozone or glycine, so that you can get the oxygen going into those tissue. You dissolve, you deliver the oxygen through the plasma or through exosomes or platelets nanoparticles or glycerine to bypass the red blood cells, because sometimes those angiopathy, they're kinked and they don't allow the red blood cells to pass through, so the oxygen does not get into those tissues. Systems approach require dynamic assessment, key tools. So it's not enough to just So you need to monitor the patient when you manage those patients with diabetes, right? It's not enough just to say, I'm going to do the hemoglobin A1C and that's it. Oh, the patient is good. Hemoglobin A1C is less than 6, so he's good. So you're doing good. Keep going, give taking your insulin shots and and without looking at insulin, without looking into endothelial function, and you're actually causing damage to that patient. You may end up heterogeneically destroying the patient. So very important. Hemoglobin A1C is good to measure. I'm not saying no because it's give you the level of sugar. Sugar is a free radical generator, but also the insulin. It's a harmful thing. And how you know it's harmful? Just measure the endothelial function. And if you find the endothelial function score is less than 50%, and you keep giving insulin, it goes low to 30%, you're killing the patient with insulin. And you are part of damaging that patient, by the way. It's the same concept with patient giving narcotics. It's the same concept with patient giving estrogen blindly or testosterone blindly without looking at estrogen dominancy. It's the same concept that we need to be more vigilant, more smart when we manage the patient. So hemoglobin A1C needs to be checked. 90 days glucose control markers. Endothelial function test, we need to check that. It's very important. So if I find endothelial function is improving along with hemoglobin 1C, that's mean your management is working. But if I find hemoglobin 1C is improving and endothelial function is getting worse, then you have insulinemia. There's something wrong there in your management. You need to focus on how to restore both and normalize both. ANS also, when you have too much of free radicals and inflammation, your autonomic nervous system gets sick, right? And you can measure that. That's so easy. The heart rate variability, right? Give you a reflection of the picture whether your autonomic nervous system is working or not. If you have abnormal autonomic nervous system, then you don't have that normal acceleration, deceleration of the heart because your sympathetic parasympathetic does not work, and you can see a flat heart rate. There's no flexibility. There's no sympathetic parasympathetic fluctuation. And it's so easy. There's very clear that from heart variability testing, you can know that patients, sympathetic parasympathetic are not working because they don't see that variability of the heart rate that normally you have, which is up and down. Pseudomotor testing is another thing. They measure the sweat. And if you have a sympathetic problem, degeneration because of autonomic neuropathy, then you don't have sympathetic function, then you don't have enough of salts excreted in the sweat, then your sweat will become diluted. Then when you try to pass electricity through the sweat does not pass well, that's mean you have neuropathy. That's mean your sympathetic is being damaged. And if you have sympathetic is being damaged, which is unmyelinated fibers, that's mean also you have free radicals that leads to damage to the blood vessels as well. And that's mean also you have damage in the C fibers as well. So indirectly, we can know that the patient has neuropathy of pain fibers, which is C fibers, is being damaged, inflamed. Indirectly, through knowing that the sympathetic is being damaged, right? Through the sweat. If the sweat is diluted, and we put your patients, they put the patient in a little plate, metal plate, and they see if the electricity pass through those sweat. If it's diluted, there's no salt because your sympathetic is being damaged from the free radicals. Then you don't have enough of salty sweat. Then it's diluted. Then the electricity does not pass. Then you have neuropathy. And if you have damage in sympathetic, which is unmyelinated, indirectly we say also their C fibers is being damaged, and that's a diagnosis for neuropathy. But it's a good test to know that the patient has neuropathy. And when you improve, when you do all this treatment, what you talked about, using all these 4 pillars of the chronic disease prevention, restore the metabolism and redox and immune regenerative and all that stuff as we talked about, then you can see the improvement of your autonomic nervous system. Your sympathetic start firing. Your sweat is getting salty enough, and in the pseudomotor testing, it's normalizing. Continue glucose monitoring is one way, especially with patient with advanced stage of diabetes, and real response to diet, stress, and sleep and therapy. All of this, it's very important to monitor the efficacy of the treatment and making sure that all the physiological process is being normalized. Those tools provide a feedback loop, ensure that the therapies are personalized, effective, and adaptive. So, insulin is indispensable, so we need it in acute conditions and emergency, but it must be used with caution. As as a long-term therapy, the system's biology's approach presented here offers a transformative module for reversing diabetes type 2 through redox balance restoration, mitochondrial and metabolic optimization, immune modulation, and inflammation control. All of this, it's part of those four pillars that we talked about: balancing the immune, metabolic, regenerative, and the redox status of the patient. Tissue repair and organ regeneration, as we talked about, all those therapies, clotho and exosomes and all that may help as well. Coupled with real-time functional monitoring, this strategy offers a realistic path to remission and complication prevention, shifting the paradigm from glucose suppression to systemic restoration. I think we end the lecture from here. This is the conclusion of this lecture. Okay, good. I think we done today. Any questions? It was long lecture, right? Almost 2 hours straight. Questions? Anybody has questions? Dr. Carol, you have any questions? You are the smartest here. We don't hear you. Your mouse is muted. And then we have Dr. Mary who's putting a lot of text there if she wants to come up to the mic. This is a platform of discussion. We don't hear you, Dr. Carol. Can you unmute yourself? This is not really one way of teaching here. This is the platform for all of us to talk. Go ahead, Dr. Carol.
Oh. Can you hear me?
Yes, we can.
Okay, Joe Mercola is promoting the HOMA IR. And that's you multiply fasting insulin by fasting glucose, divide by a constant 405. And I asked him once because I had somebody with, the results should be under 1, according to him, although if you see other resources, they say under 2. Under 1 is you don't have insulin resistance. And so I asked him about the HOMA IR compared to hemoglobin A1C. So I had a client's results, which the HOMA IR was between 1 and 2, but the hemoglobin A1C was like 5.2 or something like that. And so I asked him, which is the stronger marker? He believes the HOMA IR is a better indicator than the hemoglobin A1C. And then I heard your statistics earlier on. Ben Bickman says in a lecture that 88% of the population is insulin resistant.
Yes, around that.
Which you said up to 60. I think it's astounding, and I think it's everywhere, and it's underlying a whole lot of hormone disarray.
Yeah, because there's many factors of insulin resistance. Is the toxins, environmental toxins, it's the sex hormone imbalance that you know about. It's the obesity. All of those are overlapped. So you have the patient insulin dominant, insulin or resistance, which is diabetes, and then you have the which is part of metabolic syndrome, and then you have the estrogen dominant syndrome, which is an aggravating factor and overlap, and then you have the estrogen dominancy. The cortisone dominancy as well, and they all overlap and feed each other. And you have the oxidative stress, and then you have the histamine and the mast cell activation syndrome. They all overlap with each other and feed each other, and eventually the immune is being compromised because of that, and that's why the high risk of cancer and infections and fatigue and brain fog, it's high rocking because of all those factors combined. Can you repeat the formula of the insulin and glucose, again for us
Okay.
so we can learn it?
It's HOMA IR, HOMA-IR. And you multiply fasting insulin by fasting glucose, should be early morning, and divide by 405. So this is starting to show up. Some test results will even give you that calculation. I saw it a couple times. And the medical literature is starting to use it as an indicator of insulin resistance.
So fasting glucose, multiply the insulin level, fasting insulin over 4.5 or 405.
Multiplied by fasting insulin.
Fasting insulin multiply fasting glucose and then divided over 405,
Yes, correct.
405.
Yes.
Okay, that's a
And
good
the-
thing.
The
to know.
results should be under 1.
Okay, that's beautiful. Everybody here needs to start doing it because if as Dr. Cole said, it's at 80%, then we all need to be checked.
Yeah,
Right.
it's really, really not surprising. And we have to be checking the fasting insulin because we're missing a lot of people if we're not checking.
Great.
Actually, there is another measure, it's called Quickie, but I don't have the formula right in front of me. But so there are two measures, the HOMA IR and the Quickie are the two measures for insulin resistance. So some labs do that. In Europe, they have a lab called SynLab, and the SynLab gives you both.
Mhm.
Well, also luteal function test, if it's even good to know, because that's more even functionally showing your blood vessels are messed up, and it's not it's rigid, it's not flexible due to the inflammation, oxidative stress. So something that needs to be considered in the equation along with those lab results that we are talking about. And then, Stefan, do you want to talk about growing muscles as part of managing diabetes? Because that's your specialty there.
I have a quick question first.
Yes, go ahead.
Now, leptin resistance precedes insulin resistance. So leptin resistance comes before insulin resistance.
Did you
So-
say estrogen resistance?
No, leptin.
Leptin, of course, yes.
Yeah, leptin resistance comes before insulin resistance. So how do you correlate those two?
I'm not really looking at leptin.
No, I'm talking to Dr. Halasa when
Yeah.
he's.
Well, I need to learn from you. Go ahead. Let's
Yeah, we both need to learn.
Yes.
Yeah, so generally when people are obese, so I really think all of it comes from the estrogen pandemic that we have. So if you look at all the environmental toxin that we have in the whole world, majority of them mimic estrogen. So when we have all these xenoestrogens, they lead to insulin, increasing the insulin. So that increase in the insulin leads to obesity. So when people gain weight, then the fat cells, when they're filled up, they're not happy. So they start sending messengers to the hypothalamus. So they send the leptin to the hypothalamus to complain. And when the hypothalamus gets it, initially it's okay, I'm going to help you guys send the message down, decompress, leave me alone. But because people don't lose the weight overnight, the fat cells send more, adipose cells send more leptin. They keep on sending the leptin. Then the hypothalamus ignores it because there's too much signal going. And when it ignores it, then we get to the leptin resistance. When we have leptin resistance, then that leads to insulin resistance because now, even though we have plenty of insulin around, the fat cells do not want to perceive it anymore. They cannot get the glucose in them. So the glucose then spills in the blood, and the high levels is what we call diabetes. Now, you talked about metformin, so then people say, well, let's give them metformin. So when we give them metformin, hopefully trying to lose weight because it prevents new glucose formation. But the other factor that metformin does, it is actually promote more absorption of glucose. So some people initially they may lose weight, but down the road they gain the weight back. So they become more obese, and then they keep on feeding the whole cycle going and going and going. But now, when people become insulin resistant, they promote more estrogen, right? Like you said. So we're going to promote more estrogen because the fat cells are going to produce aromatase. The aromatase is going to convert more testosterone to estrogen. When we have more estrogen, we get more insulin, and then we keep on going. So it never ends, and people cannot control the diabetes. So if we're trying to control the glucose effect, we need to look at the whole hormonal patterns and fix the hormone system completely. Otherwise, if we focus on just insulin, there's no way we're going to control the insulin without controlling the other factors.
Yeah, I think we're the same page here. Making sure that we investigate all the sources of the free radicals and metabolic imbalance and restore it comprehensively. And the way that's being done, almost 90% of the practice, especially endocrinologists, were being trained by, the mainstream women living inside that box. Up to now, this is what they do. They say, okay, well, the tablets is not working, metformin is not working, this oral hypoglycemic is not working, we're going to put you on insulin. And they put them on insulin, they forget about any other thing except insulin. And that patients, they say the hemoglobin A1C is normal, and they're happy, and the doctor is happy without knowing that it's causing, chronic death to the patient. It's debilitating, destroying his blood vessels, burning them, firing them. You can say burning those blood vessels, but they're happy because hemoglobin A1C is normal. So that's the problem that we have. But how this message will cross to the other side of the aisle, that require us here, which is 17 or 18 people in this room, is to start, getting the message through and add more from your side, like Dr. Tano is doing, Dr. Carl is doing, and now Dr. Stefan is going to add something here. Go ahead, Dr. Stefan.
Okay, yeah, I'll give you a little presentation here. Yeah, what Carol was saying, the preponderance of insulin resistance is very high in the US. So the recent studies show that even young adults, about 40% of them are insulin resistant. And then the study she was talking about was done some time ago, 2018, found that maybe only 12% of Americans are metabolically healthy. And that's what I found in my practice too. I'd say we screen insulin fasting on all patients. We have 1,000 patients. I'd say it's not so many, really. Maybe I think that's about right. Maybe 12% have a fasting insulin level below 10. And 10 isn't a huge thing to ask for patients. I mean, you want an optimal level between 2 and 7. So as Dr. Halasa alluded to, the muscle plays a role in glucose disposal as a storage system for glucose in the body. But when you're sedentary and you have low muscle mass, the body is lazy and it doesn't know how to store the nutrients. So the nutrients you consume, they have improper storage because there's no place for them to go. There's no muscle. And so it elevates the blood sugars, the triglycerides, that you get improper storage of the energy into the liver, streaky fat in the muscle, fat on the visceral organs, the heart. Besides the liver, there's other organs it can be stored on. The muscle is an endocrine organ, just like your pancreas. This is what we have to get across to our patients and even our endocrinologist friends who don't think of the muscle as an active organ, but it controls your cytokine response. It controls your your entire endocrine system. So when you train the muscle regularly to build a robust muscular frame around your body, you improve your insulin receptor activation, and you improve signal transduction. You have increased glycolytic capacity, so your muscle becomes another storage form for energy, so that when you train, you release it from the glycogen stores into the form of glucose. That's how your body stores energy and releases it. Improve mitochondrial function. Now, here's a couple cases. This is what we see in some, surprisingly young individuals. Here's a 28-year-old male. He started out with us with an insulin fasting of 28, and he was able to improve it. He's gotten it down to 16, maybe even 9 at some points, but then fell off the wagon a bit and came back up to 17. It wasn't diabetes. If he went to a regular primary care, they would have said, well, the cutoff for A1C, I don't know what it is these days. It says 6.2. Well, he didn't really make the cutoff there. He's 5.9 A1C. His glucose was normal, like 97, 97. So most of the time he would have been like, you're normal. We'll see you next year. But we tried to do some drastic lifestyle changes for this guy. He also had very low testosterone too. We were trying to improve that. So what happens when you have high insulin levels on a fasting test? You have compensatory hyperinsulinemia. So when tissues, primarily muscle, liver, and fat, start becoming resistant to insulin, the pancreas compensates by secreting more insulin to maintain normal glucose levels. This results in elevated fasting insulin, hyperinsulinemia, where glucose and HbA1c remain normal because the body is still able to control the blood sugar, though this can go on for many, many years. So what happens long term? I tell the patients, think of it this way. It's like riding or driving your car in first gear on the highway. You're going to burn through your transmission and your engine relatively soon, maybe some sooner than others. Depends on the car. And that's the same thing with a human. If you release insulin at a high level over years and years, you're going to burn through your pancreas and it's not going to work so more, and you're going to have diabetes then. So the progression is to type 2 diabetes. Over time, the pancreas does not sustain the high insulin output needed to compensate for insulin resistance. Beta cell fatigue can lead to impaired glucose tolerance, pre-diabetes, and eventually type 2 diabetes. And that's where you start seeing, we had the final diagnosis of A1C elevation. Now we can use our metformin, we can use our GLP-1. So that's the conventional approach. This can progress over 10 to 20 years. So the person who we saw just earlier, he's 28 years old. By age 50, he ends up in maybe the primary care or even the ER with the complication of diabetes. There's obviously problematic cardiovascular risk, fatty liver disease from improper storage of energy, from insulin resistance, weight gain and obesity. This gentleman was also obese. And then you have the other complications in women. They have the PCOS, they have infertility, they have cancers. So this patient here on the right is a 35-year-old female. You can see chronically elevated insulin levels, 12.1, 13.8. She's developing HPV, dysplasia of the cervix, potential colposcopy in her future. When you have the insulin resistance, you have improper inflammatory signals. You see this patient's CRP was 8.6. I think, because on the previous day of that test, she'd actually gone to Chick-fil-A and eaten some junk food. But this just, patients don't think, it's not a big deal. It's just a little insulin resistance. No, this is cancer. This is Alzheimer's. This is cardiovascular disease. Okay? We have real problems that ensue from just, it's just a little high insulin. Your glucose is okay. Your A1C is okay. But, how to reverse this? It's training. It's strengthening the muscle. This is a cool rodent study they did. A single bout of exercise acutely reduces tumor formation after they injected into tumors injected into the mouse. So what is optimal insulin levels? At fasting insulin level, we try to target at our practice between 2 and 7. Above that, we are concerned for the patient having insulin resistance. The HOMO-IR, as we discussed earlier, is a calculation of the fasting insulin times the fasting glucose divided by 405. And then anything below 1.5 is good. And then if it's 2 to 2.5 and above, this is insulin resistance. So that's how you calculate it if you're interested in doing that. Now, this is something that I think endocrinologists should understand, but they don't. Okay. So what does the endocrinologist tell the patient with diabetes type 1 or type 2? You need to eat a carbohydrate so you can inject the insulin. But let's look at what the bodybuilders are doing in the performance world. So I work with a lot of high performance bodybuilders, just trying to keep them alive, mind you. So what these guys do, they do a super intense workout in the gym. Okay. And then they inject insulin. Okay. Why do they do this? Well, insulin is the most anabolic hormone for bodybuilders. It improves their nutrient uptake and storage. So it shuttles those amino acids and carbohydrates into the muscles to promote an anabolic effect. It improves their protein synthesis. It improves glycogen synthesis. They feel a fantastic pump in the gym. They say there's nothing else like it. Their muscles feel fuller. The whole body feels better. It feels harder. The muscles feel harder. It has an anti-catabolic effect. Insulin is anti-catabolic when it's used this way. But the timing and synergy is what matters. And this is what we're going to learn about here. So why, as Dr. Halasa said, his brother or someone said, I don't want to take insulin, it makes me fat, it makes me gain weight. This is because when you eat the carbohydrate and you sit around and you inject yourself with insulin, it makes you store fat because they have low muscle. They don't have a place to shuttle the amino acids and the fats and the carbohydrates anywhere. Where does it go? It goes into the fat storage. So yes, the diabetics, the type 2 diabetics get faster, get fatter, and the insulin and the type 1 diabetics, they get faster as well. There's an energy imbalance. So what does the bodybuilder do? Why do they do this? When they inject the insulin and they drink the carbohydrate and amino acid meal post-workout, there's increased nutrient intake from the insulin glucose transporter type 4, translocation to the cell membrane. There's protein synthesis stimulation. It activates the mTOR pathway. So bodybuilders, if you tell them to take rapamycin to lower their mTOR, they're going to run the other way. Bodybuilders love mTOR because it helps them grow. The timing is essential. So they typically will consume about I think it's about 100 grams of carbohydrates in the protein shake and aminos, and they inject the insulin. Typically, they'll use like a fast-acting one. So what can the diabetics learn from the bodybuilder? They could potentially time their insulin around the training regimen. So they can do maybe before to sustain their energy for the workout. They can have some carbohydrate meal and inject a little insulin. But definitely afterwards, in this high anabolic window where you want to use that insulin to shuttle the nutrients into the muscle. So if we're going to be using insulin in the diabetics, say they have to use it, or then an endocrinologist says you got to eat carbohydrates so that you can inject your insulin. Okay, we can't argue with our endocrinologist colleagues, but maybe we can tell the patient to do a really intense muscle building exercise training regimen and use the insulin and carbohydrates in that peri-workout window. So the timing is what matters. Don't sit on the sofa, eat a donut so you can inject your insulin. It's so silly. It just leads to problems long term. So this is a practical example, but that's really what I wanted to explain, that little optimization, how we could use insulin appropriately. We don't need to abandon it completely.
Okay, good. Any questions for Dr. Stefan? We all happy? We all good?
Everybody happy.
Yeah, nobody
Happy.
here have question, concern, wants to present, wants to talk. Just, raise your hand. Let's hear your voice.
All happy.
It's a social gathering more than any other thing. We enjoy meeting, 1 hour, 2 hours, venting what we have from the stress of the day and then go back to your life. So, but this is the time where you can, if you have any ideas, anything like that, just go ahead, release it. We want to learn from you.
Hey, have you guys, did you discuss or have you talked about the fact that sometimes the young lady type 1 diabetics don't inject insulin, and they go out and eat all kinds of garbage, but without the insulin, they don't store it as fat. It's a new thing. It's called some type of bulimia. I don't know if you're aware of this thing, but it's kind of like it's the new thing now. Of course, it causes other things, chronic renal disease and all of that kind of stuff from the high insulin, but they don't gain any fat and can eat anything they want, just as long as they don't inject their insulin.
Whoa.
Yeah,
But
I'll
those
try
just
to
have
get the
high
name of it.
glucose.
Huh?
Those just have high glucose during that time,
Yeah.
right?
Oh yeah, tremendously high glucose, but they're not storing it as fat. So they think it's a way that they can just get away with eating cake and ice cream and everything all the time and never gain weight.
You're talking about binging it out after they eat it, they throw it?
No,
No. Well,
they
that
don't
that,
have
that
to.
they don't. So that was the problem of the diabetes type 1, right? It's a wasting condition, right? Because insulin is anabolic. So what they're doing is they're not taking their insulin so that they
Right.
can go eat, because then they won't gain any weight.
Right, exactly. They don't store it as fat. They don't gain any weight, and they can just eat anything
Oh,
they
that's
want.
terrible. That's a good way to end up in the ICU.
Oh, exactly. I wish I could remember there's a term for it now that they're starting to use because it's becoming more common.
Wow, that's terrible.
Some type of insulin bulimia or something.
Wow.
Yeah, if I run across it, I'll send it out.
All right.
Other than that, we're happy.
Very, very happy. All right.
Okay, who's gonna be an AFRAM? Anybody here?
Ooh, well, I'll be there. I'll see you guys
You're
there.
gonna be there. What about rest? Anybody's gonna be there? Nobody? Okay. Well, hey, Dr. Stefan, can you give me the phone number of what's that lady? The girl, the nutritionist? Haley?
Oh yeah, I can. You want her
Maybe
again?
Dr. Klatch wants to talk to her and see if she can help Dr. Joseph in his clinic.
Okay, sure.
Can you do that for me?
Yeah.
Okay. She can talk to me and I can let her talk to Dr. Klatz, and then maybe she can just move and work if she's interested.
Okay.
Is
All
that
right.
good?
Yeah, I'll let her know.
Okay, we'll be in touch, everybody. We say good
Okay.
night. All right, take care, everybody. Good night.